Hey everybody, let's go through the pharmacology of diuretics and antidiuretics. So acetylzolamide is going to work on the proximal convoluted tubule, and it's a carbonic anhydrase inhibitor. Mannitol is going to work on the collecting duct, and the loop diuretics are the most efficacious. Thiazides are going to work on the distal convoluted tubule over here, and the aldosterone antagonists are also going to affect the collecting duct. The antidiuretic hormone also works on the collecting duct. So why does everything work on the collecting duct? So the collecting duct is like the final fine-tuning process of urine, right? So most of the water is going to be reabsorbed in the loop of Henle, but in terms of ions, it's really in the collecting duct. Like, it's our last, basically last defense before everything is excreted. So in the collecting tubule, it's going to increase the carbonic anhydrase inhibitor, and that increases or sodium bicarbonate and the pH of the lumen. So it's going to make the tubule lumen more alkaline. And it does that by increasing the reabsorption of chlorine. Sodium is going to be coupled with potassium and hydrogen excretion. So H plus ATPase and this exchanger right here. So sodium is going to come in, and potassium is going to come in, and it's going to be exchanged here. So potassium would be, brought back in, while hydrogen is going to be excreted, but it's not going to be acidic because it's going to combine with the bicarbonate. So the risk of using acetylzolamide or other carbonic anhydrase inhibitors is going to be a hypokalemia and alkalosis. So all of the acid is going to come out along with the potassium. So inside it's going to be a lot more alkaline. So the carbonic anhydrase inhibitors, acetylzolamide is going to inhibit carbonic anhydrase in the proximal convoluted tubule. It's going to decrease the reabsorption and increase chlorine reabsorption. So the problem is chloremic metabolic acidosis. So sodium bicarb is going to be excreted, chlorine is reabsorbed. So it's self-limiting. After 2 to 3 days, it's not going to pump out so much bicarbonate, and it eventually levels off. Dorzolamide and brinzolamide are topical carbonic anhydrase inhibitors, and those are going to be used in glaucoma. And because the ciliary body of the eye secretes bicarb into the aqueous humor, choroid plexus will secrete bicarb in the CSF, and altitude sickness occurs because of the respiratory alkalosis. Brush up on the physiology, if you will. So acetazolamide is going to be used to treat the metabolic acidosis and epilepsy. Okay, so of course, hyperchloremic metabolic acidosis is going to be our adverse effect. We're getting rid of all of the sodium bicarbonate, and we are reabsorbing the chlorine. The renal stones are due to the phosphaturia, so excretion of the phosphate, and hypercalciuria, so also calcium is being excreted. Hypokalemia can occur along with the hypersensitivity reactions, so it's also contraindicated in patients with hepatic cirrhosis. So the decreased excretion of the ammonia will lead to the hyperammonemia, and that can lead to the hepatic encephalopathy. Loop diuretics, furosemide is the most common. They inhibit the ionic cotransporter. So it's in the tall ascending or the thick ascending limb, and it decreases sodium chloride reabsorption. It makes that lumen negative, and so less magnesium and calcium is absorbed. And then the potassium back diffusion causes that positive lumen membrane, which is going to be that driving force. Is positive lumen on the blood side, negative lumen on the negative potential on the lumen or on the urine lumen side. So there is also a loss of the sodium in the water. That's what makes it the diuretic. Hypokalemia, metabolic alkalosis can occur. More calcium is lost. So you want to give this to somebody with hypercalcemia, right? Furosemide will increase the renal blood flow due to the increased prostaglandin synthesis. So prostaglandin is a vasodilator. This helps the pulmonary congestion and left ventricular failure. Okay, so like I said, you want to treat the left ventricular failure and the backing up to the lungs. It also used to treat renal failure, hypercalcemia, anion overdose. And a good mnemonic is loop diuretics. ET is fabulous. So ethacryonic acid, torsemide, furosemide, azoximide, and bumetanide. The clinical uses, heart failure, hypertension, and edema. Side effects are all hypo. So hyponatremia, we're getting rid of sodium. Hypokalemia, we're getting rid of potassium. Hypomagnesia, getting rid of magnesium. And autotoxicity, there is going to be problems with the ear. So the side effect, hypokalemia, autotoxicity, allergic reaction, hypo, except for this, which is going to be hyperuricemia. If given too much, there's going to be severe dehydration. Thiazides, hydrochlorothiazides, or HCT, and chlorothiazide are the true thiazides. The thiazide-like drugs are chlorothalidone, metolazone, zipamide, and indapamide. Those are going to block the sodium chloride cotransporter in the distal convoluted tubule. It's going to increase sodium chloride excretion again, and where sodium chloride goes, water follows. So there would be hypercalcemia, thanks to the increased calcium reabsorption as the sodium is being excreted. It will compete with uric acid secretion and increase the uric acid in the blood, and those actions can be affected by the NSAIDs. So there is going to be increased sodium delivery, potassium loss, and it's used to treat hypertension, heart failure, along with kidney stones, nephrogenic diabetes insipidus. We're not sure how it works, but there's paradoxical beneficial effects. It decreases the urine flow, the polyuria, and the polydipsia, so that all treats the diabetes insipidus. And by decreasing all of this, it actually helps with the water retention. Okay, so the adverse effects, really similar to the loop diuretics. There's hypokalemia, metabolic alkalosis, hyperuricemia, but it also has an impaired carbohydrate tolerance. So there is going to be hyperglycemia thanks to a decrease in insulin release. There's hyperlipidemia due to the hyperglycemia. Hyponatremia, of course, because sodium is getting excreted. Anybody who has a sulfur allergy will also react poorly to the thiazides because they are made from sulfur. In toxic doses, there can be weakness, fatigability, and paresthesia because you're getting rid of a lot of really important ions. It has cross-allergenicity, so anybody allergic to the thiazides will also be allergic to the carbonic anhydrase inhibitors, the loop diuretics, thiazides, sulfur antibiotics such as like penicillin, and celecoxib, which is I want to say it's a new kind of like monoclonal antibody treatment, or at least like a cancer treatment. So the potassium-sparing diuretics are going to antagonize aldosterone at the distal and the cortical collecting tubule, and it can occur by just like direct action. Spironolactone and Eplerenone are the ones that you need to remember. They inhibit the sodium influx through the ion channels in the luminal membrane by just decreasing the channel expression. So these are going to be hormones. They have to go into the cell and influence the expression. Amyloride and triamterene are also diuretics, and they are the aldosterone receptor antagonist. So spironolactone and eplerenone. Spironolactone is a synthetic steroid. It's a competitive antagonist of aldosterone. Eplerenone has a greater selectivity for aldosterone receptors, and both will just decrease the sodium reabsorption in the collecting tubules. Why do we need the potassium-sparing diuretic? It's for aldosterone excess. It's also given with the thiazide to treat hypertension. It's going to be given to decrease edema because it's an aldosterone antagonist. Amyloride is going to treat Little syndrome. And in the same syndrome, it's a 11B hydroxysteroid dehydrogenase deficiency and excess cortisol. You want to use this because it's an aldosterone antagonist, along with the lithium-induced nephrogenic diabetes insipidus. You use amyloride. Okay, so what are the side effects? Hyperkalemia, and this also is very, very high risk if you use it alongside beta blockers or ACE inhibitors. Metabolic acidosis, because we're getting rid of all the bicarbonate. Gynecomastia, because the spironolactone, it can be converted to estrogen in males. Acute renal failure, triamterene and indomethacin, and the kidney stones can occur. Here are the changes in the electrolytes. So carbonic anhydrase inhibitors, acidosis, potassium-sparing diuretics, acidosis, loop diuretics, and thiazides will result in alkalosis, and the potassium will be increased in all of them except for the potassium-sparing diuretics, of course. Well, in the urine. This is important, sorry. So mannitol is going to work on the proximal tubule and the distal limb, to retain the water in the lumen. It promotes passive diuresis, and it's used to decrease intracranial pressure without messing around with any ion gradient, right? So if it's given orally, it doesn't work. It results in diarrhea. So you have to give it via IV. It's freely filtered at the glomerulus, and it increases the osmolarity of the tubular lumen, so decreased water absorption. That's it's more like just a physics kind of thing. Okay, so you want to use it to reduce cerebral edema and intraocular pressure. In acute glaucoma, you increase the urine volume in oliguric patients. Side effect is going to be expansion of the extracellular volume, of course, hyponatremia. Not because you're really getting rid of the sodium per se, you are diluting it because you're retaining the fluid. Pulmonary edema, of course, and after administration, there could be dehydration and hypernatremia. It's contraindicated in heart failure and pulmonary edema patients. Because of the dehydration, it can make the pulmonary edema actually worse because of the heart. We'll be trying to compensate for everything, and then the hypernatremia is of course not going to be good for the heart. Use it to decrease edema. In heart failure, you use it alongside, or you will use loop diuretics and thiazides and potassium chloride supplements or potassium sparing diuretics. In acute left ventricular failure, you want to use the furosemide. And for kidney disease, you use loop diuretics because they're more efficacious. Acetazolamide, potassium-sparing diuretics are contraindicated in patients that are prone to acidosis, hyperkalemia, and renal vasoconstriction. In hepatic cirrhosis, you give spironolactone to counteract the hyperaldosteronism, and you don't give the acetazolamide because of the increase of ammonia retention. Hypertension, once again, use like thiazide and the potassium-sparing diuretic. Kidney stones, you want to give thiazides. Hypercalcemia, nephrogenic diabetes insipidus, you give loop diuretics because those don't mess around with calcium too much. And in little and LI-induced nephrogenic diabetes insipidus, you want to give amyloidoride, and in the same syndrome, you want to give aldosterone antagonist. Vasopressin is going to be raising the blood pressure. Antidiuretic hormone will work through the vasoreceptors V2 by increasing the CAMP. You increase the aquaporin 2 channels in the basolateral membrane and increase the water reabsorption. Desmopressin is going to be the synthetic analog, and the antagonists are conivaptan and tolvaptan. Demeclocycline and lithium will antagonize the antidiuretic effects, and that's used to treat the SIADH. So as vasopressin increases the systemic vascular vessel, it also increases blood volume, increases blood pressure in general. So the receptors V1A are in everywhere: blood vessels, smooth muscles, platelets, liver. They work with the G protein coupled receptors to constrict. V2 are in the pituitary and the kidneys, once again to increase the aquaporin 2 channels, and that increases the water permeability. It will concentrate the urine, or the receptor is going to actually dilute the urine. Because it's going to decrease the free water clearance and lower the serum sodium. If it's blocked, it's going to raise the serum sodium. Okay, so V1B will work like a neurotransmitter, and that will regulate temperature, circulation. ACTH is going to be regulated and releasing. Also has a role in learning. Okay, so V2, you can use it to treat central diabetes insipidus, hemophilia A, von Willebrand disease, also used to treat bedwetting. V2 or V1 receptor antagonists are going to be used to treat the bleeding esophageal variceles before the abdominal radiography. So this is going to constrict it enough so the varices will not bleed, but that's not the cure. The true illness is the liver disease, so you got to treat the liver disease. This is more like a band-aid solution, so you can actually perform the abdominal radiography. Okay, so these have nasal irritation, cramps, fluid retention, allergic reactions, as your adverse drug reactions, and contraindicated in people with ischemic heart disease and hypertension. Okay, so vasopressin antagonists, conivaptan and tolvaptan, demaclocycline, lithium, and conivaptan. So those antagonists are going to be used to treat the hyponatremia. So this is nothing to do with sodium. This is something to do with nitrogen in liver cirrhosis, SIADH, and congestive heart failure. So that's it for now. Thank you for your attention, and good luck studying.